So now, our panel are already on stage, and it's going to be chaired by Professor Rosemary Gowran, and the discussion topic will be sexual and reproductive health and rights. And Rosie, for those of you who don't know, is the clinical lead of the National Clinical Programme for People with Disability with the Health Service Executive. She's also an Associate Professor in Occupational Therapy with the School of Allied Health at the University of Limerick. She's an Honorary Professor with the Department of Computer Sciences at the Global Disability Innovation Hub in University College London, and she holds a visiting position at the Assisted Living and Learning Institute in Maynooth University. So she's clearly an overachiever. Rosemary, the floor is yours.
Thank you so much. It's a real privilege to be here this afternoon, and I really would like to thank Gowran and the NDA for inviting me to chair this session. I'm certainly not an expert, but I've been reflecting on this morning's presentations already, and I was thinking about some of the kind of lead advocates and activists in disability rights, like Jackie Brown, who passed away recently, and also Lee Gath, who passed away a couple of years ago. And I was thinking about her book, Don't Tell Me I Can't. And certainly a lot of the content and as she tells her story reflects many of the discussions that we've already had this morning and reflections. My role as clinical lead for the National Programme for People with Disabilities is to support the implementation of the CRPD across the health and social care sector. So it's a real privilege to be able to be in that position. And also to support some of the disability, the human rights strategy for persons with disabilities, particularly 14.1 in relation to looking at education and training on disability matters across the health and social care sector, which our programme will be leading on. And certainly this subject, this area is really critical as part of that, and we will be co-designing and co-producing content to support education training for all people who are working within this sector. So just to start then thinking about it, everybody should have access to sexual and reproductive health as a basic human right. And I think this particular session is fundamental to all the sessions that have come before and the session after this in relation to maternity care. So I'm going to get started because we've got 5 speakers this afternoon, and I'd like to welcome Professor Philip Dodd. He's the Deputy Chief Medical Officer for the Department of Health, to share his presentation in relation to the strategy. Thank you.
Yeah, listen, thanks so much, Rosie, and thanks indeed to the NDA for inviting me to speak today. This is a really important part of the UN CRPD, and it's really, I guess, exciting that the NDA places the UN CRPD so pivotal to its strategy, and that's why the focus of today, in particular on Article 23, is so welcome. Do you want me to go up to the podium, or I can stay here?
Whatever you're happy to do.
I think I'll stay here if that's okay. And the opportunity to speak about sexual health, I think, it's a really important part of the scope of Article 23. Having a good sexual health is so important for our general health and well-being. It's so important for our mental health. It's so important for the way in which we connect with each other, how we form bonds, how we show our vulnerability, but also show our connectedness with others. So it's absolutely appropriate that it would form a pivotal part of Article 23. There's also obviously significant supports and risks associated with our sexual health, including infections, and also sexual risks associated with interactions. And that's why we in the Department of Health are very focused on developing a strategic and a policy-based approach to that. And that's why I really appreciate the opportunity today to speak on the National Sexual Health Strategy, which was actually just launched. So I was hoping to just relatively quickly bring you through maybe the scope of the strategy, some of the key components of it, and very much emphasize that the strategy is at an early stage of implementation, and it very much has a rights-based focus and an inclusion-based focus on its implementation. So hopefully lots of opportunities into the future for us to collaborate across sectors. So just maybe to put it in a little bit of context in Ireland, sexual health in Ireland has progressed significantly over the last number of years. And maybe just a few points to highlight, including one of the key health challenges is the number of sexually transmitted infections. So the rates are rising both nationally and internationally. And there are also some challenges with regard to sexually transmitted infections, including drug-resistant variants emerging as well. In Ireland, we also have significant changes in our demography. We've got a lot of new Irish citizens coming to Ireland. Our population is growing, and that brings in different challenges and different dimensions to enhancing sexual health. We also have an ambition to really try and support sexual health across the developmental stages, but also across the stages that we all potentially can find ourselves in, including having a chronic condition or a disability. And then very importantly, the digital age is both enabling, but it also creates risks, and that interacts significantly with our sexual health and our sexual behaviours and attitudes. We know that there's increasing demands for services, and we've done quite a lot in the health sector to try and increase testing, and increased testing equals increased requirements for treatments. So that's another key challenge. And then we also know there are significantly changing attitudes and behaviours in our sexual health. We know on a recent trend analysis from the health behaviours of school-aged children, whereby we see our young population are having their first sexual encounter later in life, but there some concerning data with regard to access to contraception. So it's quite a mixed picture in that regard. And maybe just to flag then the other contextual broader issues for sexual health in Ireland in 2025. Obviously there's been significant progressive social change in Ireland. We had our marriage equality referendum, the repeal of the Eighth Amendment and the termination of pregnancy provisions, and then there's been a particular focus on women's health since 2022. The last Minister for Health and the current Minister for Health are very focused on improving the health outcomes of our women in Ireland. Looking at the National Sexual Health Strategy, the first one we had, which was 2015 to 2020, there were quite a number of relatively rapid achievements and expansion of services in that time period, including the development of a national condom distribution service, the development of home STI testing service. So that's very much an enabling and improved access approach to enabling people to test for sexually transmitted infections in the comfort of their own home. And that definitely has resulted in a significant increase in detection, and therefore people in an informed position then to access appropriate treatment. We've built a large but could be greater infrastructure around sexual information and health promotion. We've developed a number of HIV prevention initiatives, including pre- and post-exposure prophylaxis. And the budget in those areas are progressively growing year on year. And I think the government has shown progressive commitment to further investment in sexual health. Next. Oh, I should say next slide. It's myself. Just to quickly step back and say how we maybe developed this policy. So this new policy is building on the previous one, 2015 to 2020. There was significant consultation, public consultation and targeted consultation. There was an independent review of the implementation of the last strategy. And overall, there was, I guess, a lot of positivity with regard to the impact and reach of the last strategy. And now, I guess, in the development of our new strategy, it very much has had a focus more on broadening our focus into other policy areas. So our new human rights strategy for disabled people is very much aligned with our sexual health strategy, as is all of the really wonderful work in Cuan, the relatively newly established agency looking at domestic, gender and sexual-based violence, our national LGBTQI plus strategy, our Healthy Ireland strategy, the Women's Health Action Plans and Sláinte Care. They're all aligned with our new national sexual health strategy, as well as an eye to our international commitments under the UN Sustainable Development Goals. So there it is, our new sexual health strategy, launched just earlier this summer, and it has a very clear vision that everyone in Ireland experiences positive sexual health, and that's everyone in Ireland, and well-being, and has access to high-quality sexual health information, education and services throughout the life course or throughout life. It has got 6 core principles. The first is very much that sex positivity, promotion of sexual health, stigma reduction, hopefully stigma removal with regard to sexual health, because that enables people to come forward and get the appropriate supports to their health. There's a significant principled focus on diversity, equality and social inclusion. Sexual health is an issue for all of the population. The benefits of having good sexual health should be benefits for our whole population. A key principle is working together in partnership. Sexual health is another one of those issues that's cross-departmental, whole of population. To effectively have positive sexual health interventions, it requires us to reach in and lean into communities, other parts of the health sector, and then into other parts of our social sector, including obviously disabilities. Another key principle is our international commitments. So other countries don't have the resources that we have, so ensuring that we comply with our international aid programs through appropriate treaties, and also important to really emphasize our commitments to international surveillance and reporting obligations around sexually transmitted infections, for example. We really want to emphasize in a principled way the centrality of people in actually responding and supporting the population with regard to their sexual health. And then finally, as a principle, is really the ambition to widen equitable access and capacity through joined up approaches. So very much working in the community across sectors to ensure that we have the best possible sexual health. Just getting more, I guess, explicit with regard to what actual goals we're seeking. Enhanced sexual health promotion and education, building on what has been achieved in the previous strategy. Expanded sexual health services, increased access, and access in settings that might not have been the settings that would have been used as part of the first strategy. A key ambition and focus on contraception and unplanned pregnancy supports, and then a real focus on sexual surveillance, monitoring, evaluation and research. And I guess that research piece is critically important when you're reminded of our expanding population and new populations in Ireland. We need to learn about the way in which people's sexual health can best be supported, especially among populations to which may not have heretofore have been the centre of policy implementation as we now have. That's just a quick slide looking at the governance and implementation for the strategy, and really calling out that stakeholder advisory group. I had the pleasure yesterday of attending the first National Awareness Day for Lived Experience, and obviously the Department of Health and the HSE is very committed to placing the voice of lived experience at the centre of the way in which we design, develop and implement policy. And I think that stakeholder advisory group is a critical part of the supports for implementation. You can see there are 4 subgroups supporting the implementation as well. And maybe just to flag with regard to the theme of today's conference, we were very clear in listening to quite a number of very strong voices around more sexual health supports for people with disabilities. That's a key commitment in this new strategy, and that's something that we want to to build on in the implementation. So just briefly there, next steps. In this strategy, there was an associated action plan. So the action plan is 2025 to 2028. So for anyone in the room who's really interested in policy, policy is only as good as its implementation. And unless you have explicit action plans associated with policy, unfortunately, things don't advance. So at the centre of this is a very specific action plan. And you can see there some of the highlighted areas that we want to advance. A model of care for sexual health. I think sexual health services have developed in a more organic way, maybe up to this point, so we really wanted to design it. And I'm gone over time, so I'm going to move on. Thank you.
Thank you. And it's really good to see this strategy, but as you say, implementation and the planning for that is really important. And also that it's taking into account everything across the life course, because it needs to fundamentally start from the beginning of our education and training within schools, etc. I'd like to move swiftly on. I know we have Sara Rocha coming in online. Welcome, Sara. Sara is the Vice Chair of the Women's Committee for European Disability Forum and Vice President of the Council for Autistic People. I'll let you go ahead there, Sara, and introduce yourself and your presentation. Thank you.
Thank you so much. I'm Sara Rocha. I'm autistic. I have multiple disabilities. I'm a mother as well, reason that I could not be with you in person. And I am part of the European Disability Forum. And we built a report recently on forced sterilization in Europe. And that's my topic and what I'm going to approach today. Unfortunately, although I'm a mother, there's a lot of autistic women and a lot of women with disabilities, especially intellectual disabilities, that are not able to have kids because of this situation. So only 10 countries actually criminalize forced sterilization as a distinct offense in the European Union. 12 countries allow forced sterilization of persons with disability, sometimes as an exception of the general offense. And 3 countries, Portugal, Czechia, and Hungary, allow it in minors. So even when it's not legally allowed, for example, in Ireland, it still happens in some state members. So we do have situations that we are aware that, for example, in Belgium, in some institutions, for example, even when it's not legally allowed, it's still happening. This is a clear violation of the sexual and reproductive health and rights and a form of violence against women. Recently, the EU had the opportunity to criminalize forced sterilization across all of its member states through the Directive on Combating Violence Against Women. But relevant provisions were removed from the directive on the insistence of the Council of the EU. So unfortunately, we had the chance to actually ban it and make sure that this doesn't happen to other women with disability, but we missed this. Obviously, we were talking a lot today about Article 23 of the Convention, but this also goes against the Article 39 of the Istanbul Convention that covers forced sterilization and forced abortion, and the United Nations Committee on the Rights of the Child. So currently, there's really no mechanism for enforcement or sanctions when these articles are broken. And what we are seeing now is, even today, a reluctance from the EU to pass on laws that restrict forced sterilization across Europe. So what exactly is happening? There's an absolute absence of academic research on how sterilization is being carried out on women and girls with disabilities. But we can know some of the situations and that are leading to forced sterilization by including the voices and lived experience of disabled women that we recently tried to approach and try to understand. So some things that it's important to understand, carers and family members tend to say that they go and choose forced sterilization due to concerns about abuse and pregnancy, although obviously this will not stop any abuse. We know that there are institutions that request for sterilization as a standard. This will, according to them, prevent issues if the person is abused, but also if they have relationships within the institution. And we know medical professionals also suggesting to carers that as a best option. Finally, another reason that sometimes it is requested is menstrual management or to facilitate care. So in terms of the women that are forced sterilized, we know that some are pressured into consent or made to believe their disabilities will not allow them to be mothers. They're not fully or clearly informed of the procedure or what we'll do, or they're not informed at all. Sometimes women think it's an appendectomy. I met a woman that thought she was going to remove a sign from her belly. So there are several situations where the women don't know at all what's happening until later on, if they actually find out. Some of this is due to legal capacity laws, and this goes also to Article 12 of the CRPD, of the Convention. Some countries have legal capacity laws based on substituted decision-making, where legal guardians can make decisions in substitution of the person with disability. And this can be carers, can be family members, institution workers, doctors, and others, depending on that country's laws. So this is not, it varies a lot within the countries in Europe. So it's very important to ensure that consent, especially in forced sterilization, especially in forced abortions, in sexual and reproductive rights, that are support decision-making and not substitution of the decision, because consent needs to be of the person. As long as consent is put onto others and the third party, forced sterilization will continue to happen. Also, obviously, we need this institutionalization to make sure that we can actually reach women that were forced sterilized, because many are still within the care of the people that actually sterilize them, and they don't want to talk about it. So it's very difficult to actually reach the women, to understand what they're going through, to build the studies around this. This is coming from an ableist and paternalistic idea that women with disabilities are really unable to decide about our bodies or to become mothers. There's a normalization of violence against us, disguised as care, and the views of our bodies as to be cared for, sometimes kind of an object, as a humanization technique, instead of potential carers. So this leads to a complicity of the EU and many other organizations with eugenic practices and human rights violations currently in Europe. Women and girls with disability deserve appropriate sexual and reproductive care. They deserve to become mothers if they wish to, including through IVF, fertility treatments, and by receiving support for motherhood. But currently, none of this is happening, and in different countries, there's different levels of accessibility issues in all of the sexual and reproductive services. After most of my interventions on this topic, I'm always asked, what about the severely disabled? So I leave you with a question in a way, which is, where do we cross the line? Who is able enough to decide on their body? And who is too disabled to have rights as EU citizen and to decide on what they actually want to do with their body and their life, like motherhood. So it's really important that we continue to work on criminalized forced sterilization. Unfortunately, since the directive didn't allow us to do it at European level, we will continue to work at national level. So if anyone here that would like to see our petition, our report, you can see in the European Disability Forum website. It's important to shift the legal capacity laws towards supported decision-making and stop allowing consent to be from someone else and not from the people with disability. It's important to provide accessible information and education on relationships and sexual and reproductive health. And above all, it's important to focus on leadership of people with disabilities in the design, development, and implementation of legislation, policies, and strategies. We are often not involved. And what I see a lot when we are not involved, especially in the sexual and reproductive care, it's then we have a vision of charity, of care, that is sometimes violence disguised as care. There's a lot of comments about how, what about the people that really can't can do much, or they're severely disabled. But again, we are all citizens and we all deserve to have access to sexual and reproductive rights. And it's very difficult to draw that line. And my question is also, who would draw that line? So I hope that was...
Thank you. Yes, thank you, Sara, for that.
But happy to get any questions.
Yeah, we'll be taking questions at the end when everybody speaks, but just to reflect on, how powerful, that the message that you've made there in relation to how do we support sanctions to prevent forced sterilisation happening, and to support people to be to make informed choice and not being given misinformation, and where choices are taken away from people in relation to their sexual and reproductive health. So thank you so much for your presentation. I'd like to now move on to Professor Michael Brown, and he's going to present on the findings of the report of It's My Life, Making It Our Reality in relation to best practice guidelines for health, social care and education practitioners regarding relationships and sexuality education programs for children and young people. So thank you, Michael.
That was some introduction. Thank you very much. I need to say I'm a Scotsman. I've been here for many, many years, and I'll try and speak slowly because apparently we speak as fast as people from Cork. If you're from Cork, it's a fabulous city. So we've been working in this space up at Queen's for about 10 years, looking at relationship and education programs, and we're particularly interested in children and young people with very, very complex needs. And the work that we've done has focused on children and young people in a special education school setting. The reason being that they tend not to be groups of young people who are included in research studies. So I'm going to do 4 things, I think, in the 10 minutes that I've got. The first thing is, what do we know about relationships and sexuality in young people with intellectual and developmental disabilities? They know a lot about sex. That is the first thing. That's absolutely fact. The literature reviews that we undertook way back, they're concerned, their parents and other people involved in their care are concerned about risks and harms. Sexually transmitted infections are common. Unintended pregnancy is a concern and an issue. We looked at all the relationships and sex education programs available across the world. There may be many more that exist, but we found research studies that talked about 7. And so there are education programs there available, designed specific for the needs of people with intellectual disabilities. The content seems to be informed by professionals such as teachers, health professionals, and their parents. And what we found was that the voices of the young people were not included, not reflected at all. There was one study done in Canada where it was co-produced education program, but that's the only one that we were able to find. When we looked at the content of the programs that have been published, they're looking at issues around risk, harm, abuse, exploitation, very, very real issues. But there seemed to be an absence at the other end of the continuum. Friendships, relationships, forming friendships, issues of loneliness, isolation came up lots. And what some of the programs look at is more the mechanics of anatomy, physiology, and issues like that. So that's what we found. We could find no study internationally that looked at evaluations of the long-term outcome. So people with intellectual disabilities, the young people, they like the education programs, they enjoy them, but whether they actually bring about behaviour change over time, does it reduce exposure to STIs? Does it reduce unintended pregnancy? Does it reduce risk of exploitation, harm and abuse? We don't actually know. No study has longitudinally followed up any of the young folks. So therefore, I think there's a space there. What's their impact and what's their outcome over time as people leave school and they age? So that was the first piece of work that we did. We then got our research funding to do scoping from the perspective of the young people. What would an ideal relationship and sex education program look like in terms of content? Who should deliver it? When should they deliver it? How should they deliver it? And how would we know that the delivery has been effective in improving their knowledge and skills? That was the first big study that we did. We then got second funding, and this is more the study that I'm going to talk about now, which was looking at the co-production and the co-design of an ideal RSE program, which we did with the young people with intellectual disabilities themselves in a special school setting. And that was across the 4 countries of the UK. It was our intention to have the Republic as part of that, and we have researchers from Trinity College Dublin as a part of the research team, but I think that's going to happen next time round. So we were interested in the co-production and the co-design of these programs. Who decides what gets into the programs? The literature and the evidence that we looked at from across the world, which is mainly from Sweden, the Netherlands, Australia, and the UK, is where the main research has been done, is that professionals, teachers, health staff and their parents tend to overly influence, and it tends to be more driven by what their concerns are regarding risk and exploitation. It's completely understandable, and we're not downplaying that, because there is very clear evidence that people with intellectual disabilities are targeted and they are the victims of abuse, harm and exploitation. But what the young people told us is, we already know lots about sex, we have smartphones, we can access the internet, we watch soap operas, and we speak to lots of other people. The phrase that we decided to use was about friendships, relationships, and intimacy, because intimacy is a continuum, right through from people holding hands and being emotionally engaged, right through to doing it, the actual act itself. And they're already doing that, and they told us that. So what we were then interested in from their perspective, we have the perspective of the parents. I can talk about that at some other time if you want me to come back. The views of the professionals, which were teachers, doctors, nurses, school nurses, public health nurses, social workers. Non-government organisations are also involved in this space. But the young people told us 4 main things. They're enthusiastic to know more. Some of their knowledge is a bit confused, and the sources where they get it from sometimes may not be the most reliable. They tend to be bused and taxied from home to school, so they don't have the opportunity the way many of us did back in the day of talking to your peers. I remember some of that being quite confusing also, because they didn't know that much more than me. So maybe that's not a reliable source. They are inquisitive. They want to know more, not just about the mechanics of doing it, but a big issue for them is how they deal with conflict within relationships and the friendships that they have. The second big issue was the dynamics and the benefits of the relationships and friendships that they want to form. How do they sustain them? And if they have conflict and issues, who do they go to help them to resolve issues that they've got? And then the other issues that came up was their understanding of the experiences of what a supportive relationships and sexuality elements of their life would be. Where do they go for confidential information that's meaningful to them? I asked a group of students up at Queen's to put their hand up if they wanted to share their masturbation and their sexual health history with us. Nobody put their hand up, yet we asked people with intellectual disabilities to expose deeply, deeply personal issues about relationships and sex. So maybe it means that students at Queen's don't have relationships or not sexually active, but I don't suspect that that's true. And then the next bit, the final bit, was how they value and use the knowledge and information that they've got to make informed decisions and choices around the relationships and the friendships that they've got and how they form them. The other big issue that came up was relationships and sex education programs tend to be delivered in a school setting. Many of the oldest pupil who participate, the youngest pupil was 11, the oldest pupil was 19 going on 20, and they recognised that as they move into adulthood, gain more independence, go to college, have employment or whatever their supports are, that relationships and sex is going to be an important issue for them, and that this education should move into adulthood and into older age. So the next bit, so that's what they then told us. We're currently working with Trinity, Glasgow, Liverpool and London to look at a multi-centre study where we can actually implement the programme that they told us and look at its impact. So we are through to the final round of Research Council. So we're hoping to hear in the next couple of weeks if we've got that. And special schools here in the Republic are going to be centres for that third phase of the research study. So that's me.
Great.
Thank
you so much, Michael. I think it's really important that we understand that in relation to education and training around relationships and supporting young people and really understanding how effective that is, whether we're doing it or not, and what we're actually trying to support people with in relation to sexual and reproductive health and having good, positive relationships and being able to manage that. I'm going to move on now to our next speaker, Fiona Weldon, who's from the Independent Living Movement as a Development Officer. And Fiona is going to talk about Article 25 and position paper on that. Thanks, Fiona.
Thank you. I'm Sara. So my name is Fiona and I work for ILMI, but I've worked in the sector for a long time. I'm a disabled woman. I'm a mother and gave birth to one of my children, but I got 4 additions when I married my husband because he had 4 kids. So we had 5 boys, and so I lived with 6 men, boys, and one female. So so that was a bit of so am I on the right side historically? So I think we've touched on this earlier before, in all of the sessions, in that we're not expected to have a desire to be in relationships, to express our sexuality, or even become parents. And obviously I was wrong, because I'm a parent myself, and we've heard from lots and lots of people today. But I've worked an awful lot of time with those with intellectual impairments, and I think they have huge challenges to overcome, but they're man-made. They're created by the systems and structures, and they're often denied choices because non-disabled people are in control of their lives. But things are changing, We have lots of disabled persons organisations locally and nationally. So we have empowerment conversations. Awareness of the COPD is crucial. Our healthcare rights. My role is capacity building. So that's the age with that, so I'm still figuring that out. And like the sharing of the lived experience is a no-brainer. And no one really has the power to take our rights away because we're born rights. And so discussions like today are really important as they are lifting the veil, highlighting the real-life experiences and perspectives of disabled people. And this is kind of a very new conversation. We don't like talking about sex anyway because of our history of religious beliefs and where we come from. And so we're all sexual beings, we're having sex, Michael. So, and I think society, and I know Louise, so like, you need to come to grips with that reality, I think. Too many of us are missing out. We're locked into the belief that we don't deserve to be loved. It's shocking that we cannot have kids and we cannot have our own families because we can. Our sexuality encompasses what we wear, the makeup we put on or don't put on, the perfume, the aftershave we wear, how we communicate, and the act itself. But it can look different, to all of us, so we can be intimate in many other ways. And I think that's really important to say. Sex is one of the basic human rights of being a human, and I can't emphasize that more. People need connection, need touch, need to be intimate, whatever that looks like for them. And we need and want the same freedom as our non-disabled counterparts to discover, because it is about discovering and exploring what it looks like for us. And we're not an homogenous group, we're very different, and we might have the same empowerment, but that looks different in every one of us. But we still differ. Our lived experiences also differ. But we are humans, and comes with this is our right to be sexual beings, if we choose it or not. And I think that's important. Intersectionality embraces the idea that all of who we are and the combined inequalities that we can experience simultaneously. And I think that's, gender, race, age, because I'm over the age of whatever, sexuality or socioeconomic status and so forth. Understanding these intersectional identities is essential for the design of laws and policies and delivery of accessible, inclusive services that meet our ever-changing needs, because we need different things at different times of our life. What makes disability unique is anyone, regardless of age, race, sexual orientation, gender, or so forth, can become a disabled person at any stage of their lives. And I don't think I can emphasize that, because we don't think about tomorrow, so we don't. So Ireland must make sure that disabled people have access to both information services in relation to reproductive health and family planning. Okay, so when I was 20, I decided to have sex. and I assumed I would never get pregnant because I was different. That didn't work out. So it didn't. But like the late Selena Bunny was very outspoken about this topic. So, and some were of her work in ILMI, you know, was around discovering what we experience, and it was around inaccessible doctors, surgeries, clinics, and you know, equipment, and using long-term contraception without full consent. We did that earlier on. Negative or discriminatory attitudes from medical staff, and lack of accessible information, poor understanding of healthcare by healthcare professionals of disabled people's needs, and this comes up time and time again. Unfair monitoring of disabled mothers, and the parent capacity assessment thing. Yeah, we need to blow that out of the water, so we do. And like, you know, like we do have the decision-making service, which is brilliant, but is it working? Because we don't know if it's working yet. So Selena rightly said, the problem isn't with disabled women or disabled people. It's about the design of services and equipment. So why can we send robots to Mars? So we should be able to design accessible equipment for our healthcare service. And so different boats, same storm. And what are our issues? We know from the conversations that we've had with disabled people nationally, and you know, that we need safe spaces to talk about our sex lives and our reproductive health. It's really important. And there's very few places like this in Ireland at the moment. And clearly, we need to create these platforms. Talking about sex and reproductive health can be hard because of taboo and stigma, but I have no issue with talking about sex, so we can talk away. And many disabled people feel shy or embarrassed about the topics because many of us are not disabled parents. Some of us think that we cannot be parents, or that we cannot use services like assisted human reproduction. So like we have that right, but isn't working for disabled people. And people often assume wrongly that disabled people are not sexual. Obviously we are. And we need to have open conversations and good information about intimacy, consent, choice, and personal control. These conversations must also talk about the supports that disabled people need, not just about our sexual and reproductive services, but also about how we feel, how also we can be confident about our own physical and emotional needs. So sex positivity come in there. We talked earlier about, you know, like you need to talk about contraception because I didn't think I needed it, but anyway, that was wrong. We talked about STDs earlier, and that's really important. And many disabled people, you know, need support to access healthcare appointments, you know, and we talked about personal assistance, and I have personal assistance for maybe 30-odd years, and I do think when we talked about training earlier that we need, you know, our PAs to be trained in the area that they need to understand and support the rights of disabled people in all forms of healthcare. And it must be physically accessible, so we need to be able to get in and we need reproductive health services to work with us, so the co-design process. And also they need to be disability quality informed. So they must take part in disability quality training if they're supporting disabled people around reproductive rights and healthcare. And so training is really important, information is really important. We need to understand how our bodies work, and puberty, periods, contraception, pregnancy, fertility. Menopause is a big thing, and STDs we talked about. And PAs must be provided to any disabled person that needs it and wants to become parents. And we need state-funded disability services to take part, and I said, in disability quality training, but delivered by disabled people. So, and also we need peer-led support services. We talked about that this morning, parents, disabled parents sharing their stories. And just, I can't emphasize the need for DET, disability quality training, in any services that support disabled children and adults, and develop sexual and reproductive healthcare information, developed with us, not without us. And I suppose we need to remove the barriers, so recognize that they are barriers, and how we can, remove them, especially in regard to seeking fertility treatment and IVF treatment. And then I'll sort of close in our new national personal assistance services must make sure that we have the right to a PA, and if we need them, but at the right time as well.
Okay, Fiona, I'm going to stop you there. Thank you so much. I suppose the important piece is that, thank you, is that we need to be addressing all the issues for people to support them in this area, and that, we are all human. Any of us become disabled in our lifetime, that this is about all of us, and that we need to make it a right for everyone. So thank you so much, Fiona. I'm going to move swiftly on now to welcome Professor Margaret McGrath, who's the head of department in Occupational Science at UCC. And I'll just let you introduce your subject there, Margaret, and thank you.
How long do I have?
You've got your 10 minutes.
Okay, perfect. Yeah. So thank you for the opportunity. Thank you to the NDA for the opportunity to be here today. I've been working around issues related to sexual health for quite some time, and one of my sort of dreams is that we get to the point where our healthcare professionals are able to have open conversations with people in front of them. And I'm going to start by saying we're a long, long way from that at the moment. And it's, a lot of what I'm going to talk about echoes what's been said earlier today and on the panel this afternoon. Very often people with disabilities or disabled people, whichever term you prefer, are assumed to lack capacity, lack interest, lack ability, lack desire for sexuality, which is really surprising because people are people, and to be human is to be sexual. And I think if we talk to people who work alongside people with disabilities or disabled people, they will say, well, of course they're humans. Yes, of course I come to work to do good. I come to work with other humans. But there's an uncomfortable truth somewhere in here about what we are saying when we say that sexuality is important for everybody, but not you. And sexuality is important, but not quite important enough. And sexuality is important, and we have a whole article dedicated to sexual and reproductive health and rights, but we're still probably more interested in getting you out of hospital and reducing our waiting list and giving you equipment and talking about things about work, than we are about asking you, what are your interests, and would you like to be in a relationship, or have you found it difficult to communicate with a partner or to find or identify a partner? So the brief I got for this afternoon was to focus on work with intellectual disabilities, which is slightly nerve-wracking because it's not really my space. But I did do some work at the University of Sydney with colleagues looking at the ideas of sexual health literacy. And by sexual health literacy, we're talking about the ability to access information and knowledge, and then to apply it to your own life to help you make good, informed decisions, with good being used in the sense of what's good for you. And good for you might not be what's good for me. But the idea is that if we can promote sexual health literacy, then we know that people have opportunities to make informed choices and take risks, and everybody takes risks. And there's no exception with regard to sexuality. We all take risks, and that's part of the fun of it. So we were interested to know how that concept had been used with people with intellectual disabilities. And the short end to the presentation is it hasn't been. There's no evidence that people are considering sexual health literacy among young people with intellectual disabilities. There is, as Michael said, some evidence that there's education programs, but those programs are predominantly, as you've mentioned, based on the mechanics of sexual activity. They very often ignore entirely the relational aspects of sexuality, and primarily they're delivered in once-off situations. So unlike many of us whose sexual skills are developed over a lifetime of failures, I guess, or hopefully with happy endings at some point, many people get sexual education that's once and done, and there's very limited opportunity, particularly when socialization is restricted, for people to have opportunities to practice, to experiment, to play around in relatively safe spaces. And so we get to the point where we all throw our hands up in despair and say, but we have to protect people because they're sexually vulnerable, and therefore, rather than address what is it that we have in our society that means that people with intellectual disabilities are disproportionately impacted by sexual violence and sexual abuse, we say, well, rather than look at that, let's just stop them being sexual altogether. And our work certainly revealed quite strong evidence that sexuality is frowned upon, and that people with intellectual disabilities are often punished, both directly and indirectly, for expressions of sexuality. And that punishment might be in the form of being shamed because they express sexual desire, or it might go as far as being told you must have contraception or you can't live in this setting. And I think the ideas of forced sterilization, people say, well, we don't do that anymore. Well, clearly we do. And we do it in probably even more subversive ways than has been done in the past, because we do it for menstrual management and we say it'll be so much easier. And we don't talk about the impacts on the ability to have children. And we do it because it just makes systems work better. It's safer. And we talk about, well, we don't want people to have unintended pregnancies because they wouldn't be capable of that, which of course we know is untrue. So, in terms of the intellectual disabilities and sexual health literacy, knowledge is not enough. We also need to have autonomy and supportive social environments to apply that knowledge and to make choices and to live with the consequences, good and bad, of those choices. It's not to say that everything will work out well. It never does for everybody, but there is a lot of dignity in being allowed to take risk and to make your own pathway good or bad. The other side of my work is about trying to move the conversation along with our healthcare professionals from why would we ask about this to how could we support you to do what you want. And I'd love to say that after 15 years of working on it that we've made progress, but I honestly think it's very, very slow. We have guidelines in many of our chronic disease situations that say sexual rehabilitation is an important component of your rehabilitation post-acquired injury or disability. We have guidelines and practice toolkits to say have these conversations. But fundamentally, we haven't shifted attitudes, and that's a big challenge because those attitudes start very young. We did some research with young people about dating and their dating habits in Hong Kong and Australia. And we asked them, what are the things that you look for in a partner? And they said, well, we like someone who's funny, someone who's loyal, who's trustworthy, who, you know, is up for a bit of a laugh, will be fun to be around. Those are all characteristics that are there regardless of ability, disability, illness. They're not things that are inherently changed by our particular way our body works. And so they would say, these are the things, these are the top things that we look for when I'm looking for a date. You know, they're scrolling through Tinder and all those adjectives. But then we said, well, what about somebody who has maybe a mobility impairment, or someone who thinks a little bit different, or someone who has some mental health concerns? And immediately the barriers came up, and they said, oh no, that would be a killer. So there is that attitude issue. And if that attitude is in our general public, we'd be very naive to think that our healthcare professionals don't carry similar attitudes. And so there is a big picture item here to say, look, if we can't get Article 23 to be applied, what does that say about us and what we think and how we believe equity and equality should be considered? And so that's a long way around to saying that education alone is not enough. It's not enough for people with intellectual disabilities to access their sexuality and to enjoy their sexuality. And it's certainly not enough for healthcare professionals to get them to get on board with the idea that people have sexual health needs and would like to have those conversations. How we shape attitudes, I would love to have a bigger conversation, and I think maybe that's my point to stop, and yes, Rosie can give us some questions.
Thank you.
Thank you.
Margaret. Yeah, I think we have come a long way, but we certainly have a long way to go. You know, I'm just reflecting back on my own education, and was told your body is the temple of God in school. To now we're talking about sex, which is what the first thing Michael said to me last night when we met. So it's really important that we think about how we support people to understand, and how we are all human after all, and we need to be able to live the life that we choose, and what's good for me. I think that's what Margaret said. You know, that's the really important question. I know we've run over our time, but we are going to take a few questions from the floor, and also I have some from people online. So I wonder, is there a question from the floor there for anybody over here? We'll get a mic to you.
Thank you. I suppose I just want to address Philip, maybe. You referenced the National Lived Experience Day, and I think you're aware that there was voices missing at that table, and that event and those type of events certainly don't uphold Article 4.3 of the Convention. And I think you, as Deputy CEO of the HSE, have a remit, and I don't think you're upholding it in relation to upholding the Convention. And I think training for staff, Professor Eleanor Flynn spoke earlier, I think training for staff around the Convention, health, the Department of Health, and I know you personally haven't brought forward the Mental Health Bill, a complete breach of Article 4.3, and the Convention, you know, the whole thing around informed consent, the side effects of medication, including sexual dysfunction for some people, and a particular issue for younger people, but all people. We need alternatives to the medical model, and the CRPD mandates the state, mandates HSE, and mandates you as Deputy CEO to step up and start providing alternatives to that medical model. And if you think of women, some of whom maybe have been forcibly detained, drugged, electroshocked, some of them pinned to the bed or the floor if they reject diagnosis and don't take the treatment. Or, I mean, it's acknowledged as state-sponsored violence against women, against people, by UN Special Rapporteurs, by the UN, by the Office of the High Commissioner for Human Rights, freedom from torture. You know, it cuts across multiple articles. So the thought of some people enjoying a satisfying sex life is very far removed. They may not even have personal assistance to get out of their home, like some of our members, institutionalised in their own home. So HSE needs to really reflect on their remit and what's placed on them by the ratification of the CRPD and the Department of Health. Because sadly, we're a long way off the legal obligations and rights being upheld that the state has signed up to.
Okay, thank you for your comments. Do you want to respond? Philip, or
Well, just briefly, just to say thank you for the clear passion that you have to try and raise a really complex range of issues. And I don't think we have the time, unfortunately, today to deal with all of them. But maybe just to reference, I don't think the Department of Health in its policy in mental health in any way advocates solely a medicalised approach. Our mental health policy sharing division is very much about advocating a whole of population approach to the provision of mental health services, including the enhanced provision of talk therapies, for example. But I absolutely appreciate the significant range of challenges that you've raised.
yeah, and I think we are like there is a will and a move towards a more inclusive development.
EDF have actually got a submission in to the UN CRPD for the list of issues for that provisional stage. EDF have sent a submission. We have made one. It's not still yet up online. We don't know why. But EDF made one and called out, the violence against women, the Istanbul Convention, what steps are the state taking, and also they have a campaign against coercion in mental health. And also the Oviedo Convention, that the state needs to actually stop any engagement in relation to progressing that draft optional protocol, because it's completely contrary to the UN CRPD. And I hope in your position that you'll be able to step up. But in terms of accessing counselling and psychotherapy, what we're rolling out is human rights, supposedly, on a medical model. And let's be really honest about that. And even in Tala, just to let you know, in Tala Hospital, and it may be in other units, and maybe other people can know here, family or individuals cannot even put their baby toe into that unit. Very distressed women are expected to take visitor, even after suicide attempts, in a public corridor. Do you know, a seclusion room, an article in the journal, a seclusion room with bare concrete floor. And okay. Professor Brendan Kelly and Professor Matthew Sadler went in under the IMO banner to a health committee where the PLS was completely truncated and voices under 4.3, Article 4.3, completely silenced.
I appreciate we like
but just the violence against women in the psychiatric system, that is within your remit. And in terms of vision for change, in terms of any of those policy documents, any of those strategies, national disability, we aren't present. We're not wanted. And you don't want to hear, let's be really honest about it, or certainly to date. So I think there's a lot of work to do.
Well, we'll take your comments on board and then we can, look at this, for discussion. Obviously, we have other people who may want to ask questions and we haven't got the time today but we do take on board your comments. Is there anybody else in the audience? I think we might take one question from online. I can't. I'm just conscious of our time now. We're running over. There's a couple of questions here, and I know that we're not going to get to them all. And one of them is there is very little attention to sexual and reproductive health and rights in the new human rights strategy for disabled people. Is there a way we can use the strategy to drive progress in this area? I might be able to respond to that one. Just in relation to the work from the National Clinical Programme for People with Disability and looking at the whole area of education and training, this is, definitely an area that we will be including in relation to education training for health and social care professionals and within education. And obviously we will be co-designing and co-producing the content of any of the materials that will be produced. And we're really at the early stages of that, but just to take that on board. I think we need to wrap up there now, and I just want to thank everybody for their attention and thank all the panel members for a really interesting, we know it's complex, but we have there's a huge paradigm shift I think that needs to happen to ensure that people's sexual and reproductive health rights are met and that we move things forward. We have a long way to go, but we have made progress. So thank you very much.
Thank you.